Hello, and welcome to Docera Clinical Education, Practical Strategies for Patient-Centered Care with Next-Generation Basal Insulin Therapies in Type 2 Diabetes podcast. I'm your host, Josh Schechtel. Today's episode features Dr. Richard Pratley and Dr. Jay Shubrook discussing which patients with type 2 diabetes are good candidates for weekly basal insulin and how to use these new, longer-acting products. This episode is part of a larger educational program titled Insulin Insights, Practical Strategies for Patient-Centered Care with Next-Generation Basal Insulin Therapies in Type 2 Diabetes. For more information on Dr. Pratley and Dr. Shubrook, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
It's such an exciting time now to help people manage diabetes. We have so many tools and we've got so many different treatments. And in some respects, it's really become even more complicated. But one thing that we've had for diabetes forever, essentially, since we've been treating it, is insulin. And boy, we've had many different formulations of insulin, and we have some exciting things to share today. But I actually feel that many people might be less comfortable with insulin today than they were before, because they've been using some of the other agents. I don't know if you've seen that for you, Rich?
I think so. And I think that's something that we don't necessarily need to lose track of, because insulin is still such an important tool in our armamentarium. And there are many patients whom all of the new drugs aren't adequate in order to get people to glycemic control. And so we know that there's still this unmet gap, and insulin is an invaluable tool.
Yeah. And I think, quite honestly, most people are going to need insulin at some point in their life. If it's not for an acute episode, it'll be when they've had diabetes long enough, right? So I think we need to know those skills.
Yeah. And the better we are at understanding when to introduce insulin into the treatment regimen and how to manage it, the better our patients will thrive with diabetes, the fewer complications that they'll have. We need to share our confidence in insulin with the patients.
Yeah, I love that. I think that the idea that we have to be comfortable with insulin, and when we're comfortable, it's going to transmit that to patients. And so I think that's such an important feature. So how would you do it? I came to your clinic today. I'm here for a new consult, and you think insulin is one of the things. How would you even introduce that to me?
So that is a great question, because we come up against this all the time. And in my clinic, it's not so much of an issue because we have more of a specialty clinic and people understand they're coming there for optimization, and insulin is frequently on the table. But in many people's clinic, insulin is seen as a failure. You haven't done the diet and exercise that people told you would help control your glucose, and now you have to go on insulin. Shame on you. That's not it at all. Insulin is a great drug. We use it to get people to goal, and we use it when and if we need it. And people should get out of this mentality that it's the last stop on the train track. And it's something that can be used at any time that's appropriate to help manage patients.
Yeah, I think that's such an important message that we need to share with the audience, is that I always tell people that insulin is the one medication that can be used in every sort of diabetes, every type of diabetes, and actually at any time. It is a tool you can use when someone needs to have surgery, or they're sick from something else, or maybe they have other contraindications. So it is, by the way, the most universal tool. And the sooner you introduce it as a relied on friend rather than a rescue at the end, I think we do better for our patients.
Yeah, exactly. And the other point I like to make is that we have a lot of talk now about personalized medicine and this, that, and the other about personalized medicine. Insulin is the ultimate in personalized medicine. We give the right dose of the right insulin to the right patient at the right time, and we adjust it day to day or hour to hour according to the patient's needs. You can't get more personalized than that. And I think we don't appreciate how flexible and how beneficial insulin can be in the right circumstances for the right patients.
Yeah, and I think highlighting that we have very good evidence now that even letting your patients do their own titrations is a great way to get them to control better, and it's safe. And so highlighting that patients also are quite capable of individualizing their insulin to their needs with some guidance, of course.
It requires education, but there's nothing like an engaged and educated patient to get better outcomes. I had a individual who was followed at another clinic, and he finally learned about carb counting through some education and was able to get his A1C well below the putative targets and do so safely. And he kept scratching his head and saying, I don't know why people didn't tell me this earlier. I could have done this much earlier. And so I think that's the key message is there. You have to give people the opportunity to take control of their insulin and their lives.
I love it. So we have a great patient for insulin. What are some of the things you might want to share with them about, hey, this is why this is a good tool for you?
I always start with where we are and where we'd ideally like to be. Here's a patient who we may have tried oral medications, or they may already be on a GLP-1 receptor agonist. And perhaps they're not at goal. Perhaps their A1C is 8.5 or maybe even 9. It's not necessarily because they are not adherent to their medications. Each of these medications works in specific ways, but they all have limitations. And in some cases, the insulin deficiency that we see in diabetes is so great that nothing besides insulin can really grab control of the glucose levels. So that's the first thing I talk about is here we are, and here's where we'd ideally like to be to reduce your risk. And then I go on to here are some of the tools that can help get us there.
So I love that. So it's a one of the many tools. And we know that currently with the previously available insulins, that there is some timing importance. There's important to get it every day or sometimes even twice or 3 times a day. And that sometimes could be hard for patients. And so how do we help them stick with those plans? And then maybe next we could talk about some future opportunities.
Yeah. So that's one of the big conundrums. We know that insulin works, and it works in just about everybody, as you pointed out. And essentially, there's no maximum dose that you give. You give what the patient needs to get their glucose under control. And yet, what we consistently have seen is that patients who are treated with insulin are mostly not at goal. And so the question is, why is that? We've got good drugs, we've got good insulins, and why are they not getting to goal? One of the reasons has to do with the burden of insulin administration, be it daily or be it a basal bolus kind of regimen, and the things that people need to do to administer insulin in that fashion. And I think that's where the opportunities are for the future. If we can reduce some of the burden for patients with diabetes, for all the things that we do, then we'll improve adherence and we'll improve outcomes over the grand scheme of things.
Yeah. So reducing patient burden and then getting to that personalized or individualized care. There are now once weekly insulins. Can you tell me just a little bit about how you would introduce that and what should we know at a very broad area first about once weekly insulins?
Well, our first discussion just sort of set up the question is why would we need a once weekly insulin? And so I think this is time just to sit back and reflect a little bit over the last over 100 years. You know, it used to be that diabetes was a fatal disease, type 1 diabetes, before the discovery of insulin. And now we've changed that with insulin into one where people are living 75, 85 years with the disease and living good and productive lives. But we obviously have not stopped the innovation in insulin therapy from those very crude initial animal preparations through the years to the development of human insulins and then shorter acting and longer acting insulin levels. And I think this is a little bit of a testament to the ingenuity of our bioengineers and people identifying the gaps in therapy and thinking about ways to address those gaps by engineering different insulin products, for example. And so we've already identified the gap, and that is that, with our current regimens, people are still not getting to goal. And we think that adherence is a bit of an issue that contributes to that. So how can we make that better? And one answer is make the injections less frequent. So they last longer so that insulin effect is on board, even if they would have skipped a dose, there's still going to be insulin on board to help control the glucose levels. And so that's sort of the rationale, I think, for the development of a once weekly insulin.
Yeah, and boy, I have to tell you, I was not originally convinced. I learned so much with watching the development of the GLP-1 receptor agonist. And the idea of someone taking a daily shot, going to a weekly shot, how many more people came out of the woodwork, even before it was for other indications, just for diabetes. And they'd say, this is a really good option. And I think that's important.
And, that generated, I think, one of my favorite studies where they asked patients, which would you rather take, a daily injection or a weekly injection? Lo and behold, people would prefer to take a weekly injection. That's kind of studying the obvious. But in fact, people did prefer a less frequent dosing. And partly these newer GLP-1s were engineered to be more potent. That's part of the secret sauce. But the once weekly dosing, I think, made a huge difference. And one of the ways it made a difference is that there was a little bit of more flexibility in people's lives, and that reduced the treatment burden. I think that's one of the things we're aiming for with once weekly insulins now.
Yeah, and I would just say I'm surprised often when I go into a kind of a very specific conversation with patients. They might have a set time that they take their insulin. And, we should always encourage them the once daily to take it the same time each day. But how many times people will actually omit their insulin if they're 2 hours late? They're like, oh, I just didn't know if it was safe. And of course, we know if you miss even 1 or 2 daily shots a week, that has substantial impacts on your A1C. So these missed doses are a big deal.
Oh, yeah. That's 15% reduction in the weekly insulin dose if you miss a single day. So it is impactful, and that does add up over the days and over the months into higher A1C levels, and then we assume collectively over to less good outcomes in terms of the glycemic complications. So I do think that the once weekly notion will be impactful when we get it more into clinic. One of these medications is now approved, and so I think we're going to start seeing use and seeing some real world uptake, utilization, and really understanding what the benefits are in the real world. It's one thing to see things in clinical trials where there are expectations and there's very careful monitoring, but I think that the real test is going to be when we start to see their use in clinic and clinicians are able to see their patients lower their A1C levels, even though they've been on good insulin regimens in the past.
Yeah. And I think that's such an important point. We know the imperfections of yesterday's therapies. We are making better therapies, but even those people who are taking it correctly and optimally still have seen some benefit. So walk us through some of the introductory things that we should know about the studies as it relates to once weekly insulins, if you would.
What we do know is that these once weekly insulins have been studied in a wide variety of clinical scenarios. So if you think about the regimen introduction of insulin, you could imagine introducing it after oral medication failure, potentially on a GLP-1 receptor agonist. You could also imagine switching somebody from a once daily insulin to basal insulin to a once weekly basal insulin. And then the final scenario that's relevant is, what about your patients who are on basal bolus therapies? How would this change their management, and would it improve their management? And what we have seen is that there are clinical trials. These are large, robust trials with several hundred patients, and they last a good amount of time, a year, more than a year. So we have now a substantial amount of data that helps us to base our clinical decisions based upon these trials. So the first scenario then is a patient who is new to insulin. Maybe they've been on oral medications, maybe they've been on a GLP-1 receptor agonist, but it's time to move on. They're not at goal. And so how do you introduce those people to insulin? And this goes back to our first discussion about why do you want insulin? How do you talk to a patient about starting insulin? And it's that gap between where they are and where they want to be. And those individuals, there are good treatment algorithms that will get patients on this once weekly insulin regimen and do so safely. And the key thing that I think is important for clinicians to do is that glucose monitoring is how we're going to decide whether or not patients are on enough, or they need more, or they have too much of the basal insulin. That's true across the board, whether or not we've got once daily basal insulins or whether or not we're using once weekly insulin. So there's really no change in how we assess insulin there. We're looking at the fasting glucose levels. We're starting slowly, as we would with once daily insulins, and we're titrating very gradually. And the importance of that is that these drugs have a very long half-life, 7 days in one instance, up to 11 to 15 days in another instance. So you don't expect to see the cumulative effects manifested within a week or two. It's going to take time to get people to the best therapeutic dose. So we have to be patient when we're dealing with these drugs. But one thing that I think is important that we can lean on is our experience with the GLP-1 receptor agonists. Now there, it's a lot about tolerability. We don't go fast with those medications because we worry about GI side effects, but we're titrating on a monthly basis. And eventually we know we're going to get people to goal in many instances. You can make the same sort of analogy, I think, for once weekly insulin. If we start, we monitor tolerability by checking glucose levels, and then we adjust the levels of the insulin at a pace that is safe and consistent with the pharmacokinetics. We'll get people to goal safely.
And you said some things that I think are really important for us, the listeners, to kind of pause on, is that it's still an insulin. Insulin is insulin, and the teaching methods are still the same. You really highlighted the longer half-life, and the longer half-life is important because it allows flexibility for the patient, right? It gives them the benefit. You're looking at 7 days or 11 to 15 days as opposed to 20 to 24 hours. And I guess the question would be, and I think you've been involved in some of these trials, do they work? And the patients with type 2 diabetes, do they work?
So that's the million-dollar question, of course. But yes, absolutely they work because they are insulin. And across the board, these trials have been largely head-to-head trials against once daily basal insulins. And these trials indicate that at least the new once weekly insulins are as good as the daily insulins, if not better than, in some cases better than, by more reduction in A1C, significantly so. Yes, they work. That's our first question that we want to get on the table, is that this is insulin. Insulin lowers glucose levels. They work as well as the once daily basal insulins. But this is also a lesson that we've learned in the past when we were developing the once daily basal insulins. The question was, are they going to be as effective as something that like NPH that needs to be given twice a day? And the answer is yes. And they could do so with a less patient burden. And so now we're just extending that paradigm.
I love that you just talked about that comparison from going from NPH to once daily basal, because that was a million years ago, or felt like a million years ago. But think about how much we thought about the timing and dosing of twice or 3 times daily NPH, and what an incredible convenience it was on the clinician side to say, oh, I could just write 1 dose a day. And for the patient, you've already said that they prefer less shots, and we know that less shots means more adherence more often than not. So that as our listeners are listening about the once weekly insulin, I want them to think what you just said. Remember when we had to write NPH and then we went to once daily? Now we could go from once daily to once weekly, and how that could be really good for us and for the patients.
There was another benefit when we shifted from NPH to once daily basal insulins, which was less glucose variability. So the less variability in the insulin levels, less glucose variability throughout the day. And I think we're going to see that same thing with the shift from the once daily to the once weekly insulins. And I think that will help patients as well.
I love that. So the next question, of course, would be, okay, are they safe? You maybe be nervous that a longer insulin might cause more side effects.
Yeah. So the listeners won't be able to see us waving our hands in the air about the safety questions, but that is also one of the natural reactions to this concept. And the idea is that we're going to be giving 7 times the basal daily insulin need in a single shot. And surely that must be dangerous. Well, it turns out that's not the case. This is obviously one of the questions that was addressed early on. And, there are 2 parts to that question. One is there more hypoglycemia when you give insulin in this manner? And the short answer is no. In the clinical trials in which these once weekly insulins have been compared to the once daily insulins, the rates of hypoglycemia are, first of all, very low. And second of all, comparable to what is seen with once daily basal insulins. So that to me is reassuring. The other part of the question, though, is if somebody does get hypoglycemia, is it going to last for a week? And the answer to that is also no. They sometimes get episodes of hypoglycemia. Patients with diabetes who are on insulin do that, but they tend not to be these prolonged episodes. And those have been studied in very careful pharmacokinetic studies as well.
And I think that's such an important thing for people to know. The dosing will be another thing we talk about, but I think knowing that they are similar in their side effect profile to once daily insulins is very important. And I'm going to just play devil's advocate for a second. If you told me that agent 1 is once a day, every day, and it's got to be, within a close time to each other each day, or I could take one once a week with a little bit more flexibility, and they're going to give me the same outcome, that still sounds like a pretty good deal to me.
I agree. And I think most patients would agree. Now, there is value when we're educating our patients about consistency. So we do want to have our patients taking the insulin usually on the same day of the week. But that does give them the flexibility, as you point out, because they can pick a day of the week where it's the most convenient for them. Maybe it's Monday morning they take their shot because they always have the same schedule on Monday morning. Maybe it's the weekend because they have the ability to think about it and do it, and it works better for them. Maybe it's in the evening. It doesn't matter as long as there's some consistency around the day of dosing. And I think that's super valuable for our patients.
And so I think maybe one other kind of practical concern is how are people giving these insulins? Because it sounds like if you're giving 7 days dose, that could be a really big volume. Do you need like a bubble machine to deliver this? How does it get delivered?
So it's a really good question. And yeah, that's sort of the perception, with somebody coming at you with some giant syringe. But that's not the case. It turns out these once weekly insulins are extremely highly concentrated. There's been this evolution in insulin dosing. Most insulin, of course, is U100, but that's sort of historic. Initially, insulin doses were, U10 and U40. So U100 has been the standard for a long while, but we've seen now the U300 once daily basal insulin is a very successful product. The advantage of that is that it's a smaller injection volume. So some of these newer insulins are U700. So think about it. For the same dose of insulin, the volume is going to be identical. So we're not coming at people with a huge syringe.
Yeah. And as we think about this, again, I love that, this is going to be devices that are similar to what many clinicians are already exposed with, and there's not large volumes because it's concentrated. Are you making any, this is going to be a complicated question, but like, as we have other therapies on board, are there other therapies we have to change when we start once weekly insulin compared to once daily insulin?
Well, I think it's the same general idea, and that is, going both ways. If somebody is on a GLP-1 receptor agonist and they're stable and above goal, we don't really think about changing the dose of the GLP-1 receptor agonists, but actually going in the opposite direction. If somebody is on one of these once weekly insulins, or indeed on a basal insulin, and we start a GLP-1 receptor agonist, which have very potent glucose lowering effects, we're going to want to dial down the dose of either the daily or the weekly insulin. And that typically, in my clinic is 10 to as much as 20% or so. I think with the once weekly insulins, we're going to want to be pretty conservative so that we don't run into problems with hypoglycemia. But also remember that as you're up titrating the GLP-1, the effects are going to be gradual. So we have the opportunity to adjust the insulin doses gradually in tandem with the adjustments of the GLP-1. And I think that makes a lot of sense.
I think ultimately insulin is insulin. And so you want to be smart to reduce things that would increase the risk of hypoglycemia. But whether it's once weekly insulin, once daily insulin, you're starting insulin or you're titrating or switching insulins, and the same warnings and kind of precautions would be present. And I do think maybe this is not what our kind of original question was, but I love letting patients get off other medications if we feel insulin is right for them and we feel like it's going to be part of the long-term plan. And so, helping reduce the burden of their overall medications when we know insulin's necessary, I think it's a psychological win for patients because sometimes they feel like, oh, you're just adding. But here, if we say you have a once a day or once a week and we were to do some meds, they might like that.
Yeah. Yeah.
So as we think about this, you got a patient who's excited, you've got them that they are interested. In terms of anything unique, is there any counseling that you're going to tell them initially when you start this once weekly insulin?
Yeah, I think there are 2 or 3 important points. One is we already mentioned the consistency of dosing on a given day. The second thing that I want to make sure my patients understand is that we're going to be following the glucose levels. They have to be monitoring their fasting glucoses as a minimum. Now, there's a role for CGM here as well. And I think that's a super way to be able to monitor the safety because not only do you get the picture of their fasting glucose levels, but you get the whole profile. And particularly, you get a window into nocturnal hypoglycemia. And patients may not experience or report that as a physical symptom, but the CGM can pick that up. And that will also help guide the titration of the insulin. So glucose monitoring is the second key thing. The third thing that I want to make sure my patients understand is recognizing the signs and symptoms of hypoglycemia and how to treat it. This is true with all insulins, but they need to understand what we're looking for when we talk about hypoglycemia, low blood sugars. Now, people have different symptoms for lows. I completely understand that. We need them to understand what to look for, and then importantly, to check their glucose levels, and then how to treat their hypoglycemia. So I think those are the things that will get us good adherence, safety, and confidence in using a once weekly insulin.
Yeah, and that confidence is so critical. When someone's going on insulin for type 2 diabetes, they may feel like this is a big step. So if you were going to start someone on basal insulin, you're going to give them the once weekly basal insulin, you gave them a titration plan, when would you see them again or check in with them?
So that's a great question. And remember, they're going to be dosing infrequently, and it takes time for the insulin to accumulate and for it to have its maximal effect. So what I expect to see is that gradually over 2, 3, 4 weeks, we'll see the glucose levels coming down. We're going to be monitoring fasting glucoses or using CGM. And probably what I would do is have these people report back to my clinic. I don't necessarily need to see them in clinic, but I want to see that they're making progress. And I would give them some parameters. If your glucose levels are falling within this range, then we're going to stay at that dose. And that range may be 90 to 120 for a fasting glucose, for example. That can be individualized for different patients. You may want a higher threshold for some people, but patients need to know what the expectations are, what their measure of success is. And if you give those parameters to them, then very often they'll be comfortable adjusting the dose of the insulin. I would love to see my patients, though, within 4 to 6 weeks, just to assess how they're doing on this new product and address any concerns that they may have. And that's hard to do just looking at numbers kind of remotely. So I do want to have a little bit more careful follow-up when we're initiating. After they're comfortable with the titration and moving along, then we go back to our regular schedule of, every 2 to 3 months of seeing patients, depending upon their needs and their intensity.
Yeah, and for those of you out there in primary care, I think one of the magic of many diabetes centers is this team that's helping the patient. And so I would really encourage primary clinicians to not go it alone. And, as Rich described, and I think it was really important, you give them a clear starting dose. You give them parameters for titration, and you tell them what the ceiling dose will be before they're supposed to make more changes. And if you give those parameters and you use things like a team-based approach with telephone calls or telehealth, and you're using CGM, you can really do this quite eloquently and in almost any practice setting. So utilize that coverage of CGMs so you can see the data, you can see improvement, and you can tell to the patient, oh, by the way, your estimated A1C or GMI was 9.5, and now 2 months later, it's 7.5. And that is feedback that will help them stay on the course.
Yeah, exactly right. We're privileged to be able to use Epic, and we have MyChart. And so I have patients send me messages, and it's quick to be able to respond to those messages. Yes, you're on track. Or, I'd probably go up, on your insulin dose to X, Y, or Z, and then tell me again in 2 weeks or 4 weeks where you are.
You've mentioned that we could use once weekly insulin for people who have failed or needed something beyond oral therapies or people from other insulin regimens. But let's say that we have someone who is on a once daily regimen, and we think that the once weekly regimen is going to be a better option for them, and the patient endorses it. What's that look like in terms of the math? And let's just put some parameters around it. They got to an A1C above 8.5. They're adherent with their medications, but they just would like the improvement in the dose burden going to others. And they're just on basal insulin and oral therapies that don't induce hypoglycemia.
Yeah, so in some ways, having somebody already on a daily basal insulin is perhaps the easy scenario because you have a starting dose for their insulin. And that gives you the ability to see what they should be in a weekly dose. And it's pretty simple math. You can multiply by 7, and that's your dose for the once weekly. Now, if you have a patient who is above target, in the case that you mentioned, an A1C of 8.5, you clearly have some room to play. So, for example, if you do the math and it's less than you can practically give with the insulin pen, then you can round up a little bit to get that round number of the weekly insulin dose. And conversely, if you have somebody who's already very close to goal, be very careful about rounding up when you're converting to the once weekly dose, and maybe round down a little bit, and then titrate as necessary to get to goal. But really, that's not a very difficult scenario, and most of us are capable of that in practice.
So I think we've highlighted a couple things. So first of all, we know that there's already missed opportunities with insulin dosing in our patients with type 2 diabetes. And while it's the most effective and the most easily utilized medicine and titratable across all meds, we still have many people who don't end up staying on it or achieve the goals. So this opportunity of a once weekly insulin allows us to do personalized or individualized therapies, allows us to reduce the burden and probably the stability of that therapy. And given the same tools you would use with any other insulin, we could be quite successful with once weekly insulins like the others, because it's really just a matter of doing the specific math of that dose. And we've learned with other medications that once weekly dose, if it's put in context, should not be scary at all, because it's exactly what they're doing with shorter insulins. So I love the things that you shared today.
So Jay, you've gotten my perspective on why we should be using or could be using once weekly insulins, a little bit about the patient profile and a little bit about the dosing. But I'm really interested in your perspective about how you think this would fit into your clinic. You see a wide variety of patients with diabetes, and I'm especially interested in how you would use a once weekly insulin in your patients who maybe are not at goal.
Yeah, so that's a great question. And I think, every practice is kind of unique about what they look like and the tools you have. But, I first and foremost am comfortable with insulin, and I want my patients to be comfortable. Even if it's not the tool we use now, it might be a tool we use in the future. And so I usually will set the stage and say, this is our plan now. We have this whole range of tools, and we may need all of them at some point. So none of them are off the table because we want to help you for what you need. As we think about choosing an insulin, it's really best, at least in my practice, to give patients some agency in decision making. And so if I think, and most commonly I'm going to use basal insulin in type 2 diabetes as the first insulin treatment, I now have a choice. I can give them things that are a couple times a day or things that are once a day, and now an agent that is once a week. And I do think having that patient buy in and letting them figure out the kind of dosing in their life is part of it. So I think I'd start with that very big background. And then as we get into the details, we always teach them the first injection in the office. We want to make sure that they know how to do it. This is something that may be foreign to some people. And when they're doing it, I want to let them know what to expect if it's not right. Like, I don't expect you to smell your insulin after the injection. You may not be getting it. I don't expect you to have a lot of pain. It's much less painful than doing a finger poke. So those parameters, so they know when to reach out. When I'm looking at a once weekly insulin, I think I've learned from the longer acting medications are going to give me stability, and they're going to give me the ability for the patient to have reduced burden. And I think if they can see that a single shot a week can do the job, I'm very happy to talk them through it. And I'm actually not concerned about the dosing per se. We have people that take 1,000 milligrams of metformin twice a day, and they take 1 milligram of glymepride. And boy, I'll tell you, I'm much more worried about the glymepride than the metformin. And I actually tell my patients that the number is kind of not the number you think it is. It's not a linear scale when you think about the potency, because the way it's delivered will look a lot like the once daily. You're going to get a small amount over a longer amount of time. And so because some patients will say, and they have asked, well, wait a minute, that seems like a big dose. There is no big dose. We always calculate the dose by a weight-based dose if they're new to insulin. And as you mentioned earlier, the idea of having already an insulin on board, we know exactly what dose to start with. So I think I answered your question there, but if not, you can ask me part two.
Yeah, that was nice. I'm going to make it tough for you now, though, because this is a common scenario. And then you have a patient who, has been doing okay on maybe metformin and an SGLT2 inhibitor. And now you're coming to the time where you're considering an injectable therapy. And you have a choice. We have lots of great GLP-1 treatments, and now we have either once daily basal insulin or once weekly insulin. How do you think you would go about that discussion? Because this is a real life scenario that people will encounter.
Yeah. So, and it is an important question, and you might get 10 answers from 5 clinicians. But, I think first of all, these are all potent agents. If you're looking at the long acting GLP-1s or any insulin, they're potentially potent. So if I have ways to go, they're great agents to use to help patient get to their goal. If the person has primarily a glycemic problem and does not have any other compelling indication, and maybe they have low to normal or only slightly increased weight, and they don't have heart disease or kidney disease, then we have all of the choices. I'm actually surprised when I introduce that way, how many people actually say, I like the idea of insulin because my body makes insulin and I'm going to have less side effects. And I think that's one of the things about insulin compared to GLP-1s is that if there's not a compelling indication, it's the most titratable medication. It's one that can stop and start, and there aren't going to be these other things that we have to worry about. Now, when we choose between a once daily and a once weekly, I think if it's brand new to injection therapy, I'm going to have a discussion and see how comfortable they are. They may have a really strong preference. And if they do, I'm going to follow that. And I think many would want once weekly. If they're tentative, I might start with a once daily just to make sure that they get the comfort of it and we can see that it's going to work. And then I'll give them the choice. Do you want to stay with the once daily or do you want to go to once weekly? But I think there's a lot of ways to do it.
My perspective is there is so much hoopla about the GLP-1 receptor agonist, and some of it's well-deserved. They have very important effects in cardiovascular disease, kidney disease, a variety of other complications of obesity, and there's the benefit of weight loss. But I also see in my clinic, there are patients that don't want a GLP-1 receptor agonist. They don't want to lose weight. They're not necessarily afflicted by some of these comorbidities where there's a clear indication. And I think that happens more often than we potentially realize. So I think we need to have, just as you said, a discussion with the patients. This is where that shared decision-making is so important. They need to understand what the options are and that there are several options that are all good and that will get them to their goal. I think that's a really important concept. How would you, in your clinic, manage concerns about hypoglycemia? Because I think this is one of the key fears that patients and especially primary care docs might have about initiating a once weekly insulin. How would you advise them?
Yeah. So I think first and foremost, if they're on any medication that could induce hypoglycemia, most commonly sulfonylureas, glutamides, or insulin, I talk to them about looking for hypoglycemia, letting us know what the symptoms that they experience, because everyone's a little bit different, and that we teach them about the rule of 15, so we give them glucagon. So that's true of all those therapies, not different between once daily and once weekly. And then I also try to share with them about when would you expect it? If it's a basal insulin, it's going to be more likely to be times between eating or maybe overnight. So giving them targeted ways to take a look for it. And then I also highlight that because it's highly titratable, and most often we have a plan, we can usually prevent that by saying, we're going to start with a weight-based dose. We're going to titrate once a week or once a month if it's once weekly insulin. And we're going to look at your CGM data or your glucose data so you can land softly. And that's really what I tell my patients is, we don't need you to land a plane in a minute. We're going to land it over 40 minutes slowly so that you can adjust to it. And you're going to see your sugars change. And you'll probably start to tell me when you're feeling uncomfortable. But I hope that you don't, because you'll see that we have a plan to get you there.
Yeah. One of the questions that I sometimes hear is, do you really need an insulin in the setting of a GLP-1 receptor agonist? And what I do see is that many people don't respond fully to a GLP-1 receptor agonist. But the other thing that we have seen is that a combination of a GLP-1 receptor agonist and either a once daily or even a once weekly insulin is a very powerful combination for getting people to target, and doing so, again, with a minimal amount of patient burden. And I think that's one of the things that potentially is going to be transformational in type 2 diabetes. We're going to be able to get more people to go by using these very powerful medications in combination. If we're willing to help coach our patients through the initiation and help them get comfortable with the notion of insulin. So what do you see as potential barriers to implementing a once weekly insulin in either your clinic or in other people's clinic?
Yeah, so it's a new agent. It's going to take time for people to be familiar with it. If you're not using a lot of insulin, that might be really new and different for you. And that might be something that makes you pause. I think talking with patients, if you don't already have a kind of a standardized approach to your patient to introduce insulin, this is going to be something that you'll need to develop. And then I think also having that discussion with the patient about what to expect.
One of the things that I think helps when people are considering a new agent, one that they maybe not have much familiarity with, is what does the ideal patients for this drug look like? And who are patients that we should avoid? Do you have any thoughts on those things?
For sure. So first of all, I love that question because those are real world questions. So who's going to be not a good candidate? If I have someone that I'm already struggling with their engagement in their care, that may not be the best person to try a brand new agent on, especially if they have a chaotic lifestyle or maybe they have unstable components that may make that component of treatment harder. I also think if someone's already having frequent problematic hypoglycemia, I've got to sort that out before I make a change to their therapy. And so I think that would be another thing that may pause. In terms of people starting it, I think the ideal patient is someone who understands the benefit of insulin therapy, is comfortable with insulin therapy, and can see tangible benefits from it and would benefit from a once weekly injection or more stability in their control than they get with their current therapies or once daily therapy.
Yeah. And that's the other scenario where I think CGM could be very helpful. I mean, we love it because of its transparency for our glucose profiles, but there's that day-to-day feedback that patients get and what their glucose levels are doing. And that's both positive and reinforcing when you're using insulin. And it also adds a measure of safety, I think, to people's lives. It helps the whole management of patients with diabetes on insulin.
Yeah.
Well,
I might
go
add
ahead.
one more thing there. And I think it's important to highlight that if you're new to once weekly insulin, think about who's going to be a good candidate. Pick the person that's going to be the right person first so you can get comfortable and know that which person you're not going to do it in. Because I think, again, ultimately, it's going to be a burden for you and your patient if it's not a good match. And take the time to do shared decision making. Because when you do that, you're going to have someone who's engaged in the plan. So I do think that's it. And I also highlight that these are all going to be branded. And so cost will be an issue. And so certainly I'm going to talk with the patient and offer it to people who can either get access through their insurance or through other methods, rather than having someone go to this if it's not covered. Sorry.
Yeah. These are all great points, Jay, and I think that you've really helped to highlight the potential role of a once weekly insulin in clinical practice and especially in primary care, where it could make a huge impact. I want you to think about your clinic and think about from your clinic, what might be an ideal patient you would use a weekly insulin in?
Yeah, so we literally just this week we had somebody who came to us for a consultation who had been on oral therapies, A1C had climbed, they had really targeted therapeutic lifestyle change and still didn't quite get the goal. And so the clinician in the field had put them on a GLP-1, and they actually saw improvements in their glucose without too many problems, but they did say they had side effects even on the lowest dose at 12 weeks. And they were pretty unhappy they were losing weight. And when I saw their BMI, this is an older woman. Her BMI was 24 before she started. And I don't consider that a contraindication to a GLP-1, but a little bit of weight loss in an older person may not be the best thing for them. And so I asked her, I said, well, what is it that you like about it and what is it you don't? And she really kind of talked about that loss of appetite. In fact, she was drinking less water as well. And she also didn't like losing weight. And I said, well, there are other choices. And so I said, you could have done insulin, that would be an injection and you wouldn't have those side effects. And she said, actually, she took it once around one of her surgeries. So she was very comfortable with it. And she asked me literally, well, when are they going to make it like the shot I take once a week? And I'm like, good timing, because you now are starting to see this as an opportunity. And so I do think there are places where it's a very good fit.
So you mentioned an older individual, and of course, one of my passions is diabetes in older individuals. I can think of some reasons why older individuals, we might want to be more careful with a weekly insulin. In one instance, they are a little bit more susceptible to hypoglycemia. They sometimes lack the counter-regulatory responses. And, we do get concerned about over-treatment of older individuals. Again, balancing the risk and benefit. What do you think about the older individual with type 2 diabetes and a weekly insulin? Is this something that we should avoid? Or do you think this is something where there are opportunities if we think about them carefully?
Yeah, I think we have to frame it with the person in mind, right? So older, it can be an age, but it can also be a physiologic state. And so, what is their relative level of complications? What are the other factors that are involved? I always worry about mobility. So if someone's on insulin, I have to know if they drop low, can they treat themselves? And so I will inherently pick a higher A1C goal for most older adults, but certainly those with complications where I'm worried if they can't get there. Now, I would also say the once weekly insulin is great in its stability, but if their life is inherently unstable, that may not be the best agent for them if they have other things that might complicate their intake or their activity. So I guess it's taken with a grain of salt. And maybe that wouldn't be the first patient I put the once weekly insulin on. I get experience, get comfortable, and then decide.
Yeah, this would be another great instance where CGM would be helpful. We've shown that older individuals do very well with continuous glucose monitoring. They monitor their glucose. They tend to wear it more than younger individuals, and they make some real life decisions based upon the CGM. So that's another opportunity. All right, got another clinical scenario for you. I'm about to hop on a plane to India. This is true. What if I were on one of these once weekly insulins? What would you advise me?
Well, the good news is it should be quite a bit simpler because you might not have to dose on your flight. You would be able to have the background therapy available. So I think it depends on the day your shot would be due. But because it does have a much longer half life, you could do more frequent monitoring and even pass your time during that flight and not take that shot so that you had that background therapy and reassess on the other side because we know even time changes are going to do different things to your glucose, and so there's a multi-level factor, not just the trip itself.
All right, another difficult clinical scenario. Say you have a patient on a once weekly insulin and they have an acute medical illness, maybe a gastroenteritis, or they need surgery and they're going to be in the hospital. What issues do you see there?
Yeah, so I think in some ways it's harder, in some ways it's easier, right? So I think that there have been studies that have shown across a wider range of physiologic conditions, these once weekly insulins do similar to once daily insulin. So you're not going to have more hypoglycemia per se. If you do have hyperglycemia because of an illness, you may have to have a sick day plan, which may involve correction insulin because you're not going to have time to titrate the once weekly. But I would say for the hospital, anybody on insulin, you should have appropriate monitoring of the patient and should have plans to address high or low blood glucose. There'll just be less injections. And in fact, most hospitalizations, they may not get any injection during that time because they would have had it within 7 days.
I think that's one of the key messages in our hospital when patients are with diabetes are hospitalized. They do get routine monitoring of their glucose levels, but they also largely get taken off of their oral medications and they get put on insulin. And that could be a little bit problematic if they already have a long-acting insulin on board. So I think communication with the hospitalists and having the patients actually be able to convey to the emergency room or to the hospitalized patients that they're on a long-acting insulin, that's important. The same thing might actually apply in people who are undergoing scheduled procedures like endoscopies, colonoscopies, things like that, where sometimes medications are held. They have the insulin on board, and they're not going to be holding that insulin. We don't advocate them holding their daily basal insulin beforehand anyway. But I think it's important for them to make sure that their anesthesiologists and proceduralists are kind of aware that that's on board. And they would ordinarily have routine monitoring as well. How about patients with declining kidney function? Any concern there?
Well, certainly we see people who are on insulin who have declining kidney function can be at higher risk for hypoglycemia. And so we want to be mindful of that. Sometimes that'd be the first indication. Someone's on insulin, they start having lows. That's part of my evaluation. Has there been a change in their ability to metabolize insulin? I do think inherently they're going to have a higher A1C goal anyway, if they have chronic kidney disease or cardiovascular disease. So I think being mindful to know where they're at physiologically and adjusting so that they have the wiggle room to be safe is probably what I would do. But I think it really depends on how much change, and what are the other co-founding factors for the patient?
Yeah. Gosh, we've covered a lot of ground here. There are obviously going to be other clinical scenarios that come up when we're introducing once weekly insulins into clinical practice. But I think the take-home messages are that these drugs are effective, they're safe. In terms of hypoglycemia, you have to keep in mind the difference in the pharmacokinetics and the half-life of these medications, because they do really last a long time. But there's very clearly patients who benefit from the reduction in burden, and we look forward to seeing improved outcomes in our diabetes clinics.
Thank you, Dr. Pratley and Dr. Shubrook, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Insulin Insights, Practical Strategies for Patient-Centered Care with Next-Generation Basal Insulin Therapies in Type 2 Diabetes, please click the link in the show notes. And be sure to check back regularly for more episodes on important topics.